today. I'm Rachel Bromley, TMA Senior Manager of Patient Education Support and Advocacy. And behind me, you will see a lovely view of Dallas, Texas, where our next myositis conference will be held September 18th through 21st. Hope you are able to attend. If you have mobility issues and cannot attend, there will be a package of recordings to purchase. For those of you joining us for the first time, we're broadcasting from Columbia, Maryland. We'd love to know where you're tuning in from, so please feel free to share your location in the chat box. Make sure that when you share, the message goes to everyone and not hosts and panelists so that everyone can see where everyone else is tuning in from. Since 1993, the Myositis Association has been dedicated to improving the lives of those affected by myositis, fund innovative research, and increase myositis awareness and advocacy. We envision a world without myositis, and we work tirelessly to get closer to that goal every day by providing education, support, and resources to the myositis community. You've let us know that our Ask the Expert webinar series is one of the most valuable ways we engage with you. Each session features experts from TMA's Medical Advisory Board or other distinguished members of the myositis medical community, and today is no exception. We encourage you to take advantage of this opportunity, ask your questions in the Q&A box, engage in chat, and remember that what you learned today can be shared with your care team, family, and friends to help educate others about myositis. And now I just have a few housekeeping slides that I need to go over. One moment. All right. Let me go into present mode. Okay, TMA does not give medical advice. Our educational webinars are informational. We encourage you to make all decisions about your care in partnership with your healthcare team. TMA is very grateful for our expert speakers from all over the world. We ask each speaker to disclose any potential conflicts at the start of their presentation. This webinar is being recorded and will be available on TMA's YouTube channel on the 1st of next month. Please put any questions you have in the Q&A box. Pre-submitted questions are being loaded into Q&A as we speak, so you do not need to put questions in that you already submitted when you registered. A warning though, questions put in the chat box may be missed, so please use the Q&A box. TMA evaluates its programming to ensure we are meeting the needs of the myositis community. A survey will pop up at the end of the webinar, and we ask that you please take a few minutes to provide input to inform future programming. So I am so honored to introduce today's speaker. Dr. Lisa Christopher-Stine is a professor of medicine and neurology and the director and co-founder of the Johns Hopkins Myositis Center, a multidisciplinary clinic formerly established in 2007, and she also currently serves on our TMA board. So with that, let me highlight Dr. Christopher-Stine. Add spotlight. There you are. Hello.
Hello. Hi. Thanks so much, Rachel. In order to get started, my understanding is that the first business for me today is to reveal my disclosures. This is the hardest part of the whole session. Let me see if I can show this to you. All right, I'm going to share this, I hope. All right, let me just, hopefully you're seeing what I'm seeing. Yes,
we are.
Okay, so these are my disclosures for viewing. I know this will also be available by the web. I won't read every one of them, but I want to make sure that you see that I do consult with a lot of companies in the effort to try to find better therapeutic options for all of you. Okay, so I think I have stopped sharing, correct?
All right, well, we will get started with the questions.
Thanks for the love. I see floating hearts. I'm feeling very honored.
Yes. I'm sure there's lots of love in the chat also.
Well, I get blue hearts, red hearts. Wonderful. Thank you.
What research is in the pipeline for addressing IBM's degenerative component?
Good question. I see so many IBM questions ready to be loaded up, so I know this will probably be a bit of an IBM heavy discussion, although I'm hoping we'll get to all forms of myositis so everyone feels included. It's also a lot, I guess, Rachel, I have just under an hour, correct? Or is that right?
Yes.
So we have a lot of time together, but that time goes quickly. One of the pre questions I think that had come in was, please speak slowly and explain all medical terms. I have no problems telling you about medical terms. I do have a problem speaking slowly, so I'll try to moderate myself. I always want to tell you so much in so little time. So I would say that this is it's a curious question. So, and the reason that I assume that the person is asking is that we are still debating, at least I am, whether IBM is a degenerative disease, an autoimmune disease, or both, or one becomes the other, or they're simultaneous. And it's interesting in that later I think there's a question about who should I see? Should I see a rheumatologist or a neurologist or both of them? And tell me a little about that. We'll get to that, I think. But I think that we're not 100% sure that we can decouple those. So when you say, what are we doing for the degenerative component? If you think about IBM as a neuromuscular disease, and when we think about degenerative muscle diseases or neurologic diseases, IBM's unique because there is definitely a strong inflammatory component. It's debated as to whether it is truly, quote, autoimmune, right? Because a lot of the traditional immunosuppressive agents that we try generally don't work. That may not mean that it's autoimmune. It may not that it's not autoimmune. It may mean that we haven't found the right pathway. And I know that's a lot of folks who think a lot about this disease, as I do. That's sort of the logic there. So I'm careful to tell you that I'm not sure I can decouple the degenerative component from the inflammatory component. By definition, IBM will be a degenerative disease if the inflammation or if the disease itself is left unchecked. We know that. However, what has perplexed obviously both patients and physicians, and I'll be clear that I've always say I'm in the business of hope. For every form of myositis, this is true. IBM has been the most challenging, but I've always remained hopeful because I think as science accelerates, we know more, we do more, and we're seeing that even in real time. Not fast enough for all of you, I know, and certainly not fast enough for me, who I don't want to see another patient who is waiting for me to tell them that I have more information. So I will speak to you in the ways that I know it. In addition to waiting for other therapeutic agents in the pipeline right now, I know that there's a little flutter of some. There's none that I can disclose publicly yet, but I can tell you that a lot of companies have expressed interest. And I think I see some novel thoughts on the way that people want to attack this problem. Today, as you know, there is a trial by Abcuro looking specifically at it's a precision mechanism. They're looking at targeting KLRG1, which is a marker on those killer T cells. Cytotoxic T cells is the medical term. Killer T is easier to remember. And you know, those are that we think are the bad actors. And so you say, well, you're not talking about the degenerative component, but I think they're linked because if we are not taking away the autoimmune component, will continue to see degeneration. So I think it's a little bit difficult to separate them. So I do think I'm hopeful. We're all hopeful. I think we've tried and failed several therapies in IBM, and it's been frustrating. I do like this targeted approach because it wasn't a Me Too approach. It was a targeted therapy designed with the science in mind, trying to be precise and trying to target specific cells. And that also decreases any immunosuppressive risks when you're only trying to look at one portion of the immune system, like those particular cytotoxic T cells, those killer Ts. In addition to waiting for therapeutic agents, I'll talk about this will be a theme I'll talk about more and more. I have come to realize that I underappreciated the value of physical therapy and exercise. And before you roll your eyes and say, "Are you kidding? That's what I'm going to hear about exercise." I think there's something to exercise beyond just increasing muscle mass, just increasing endurance, and maintaining one's function. It certainly does all of those things. But I do think that, and hopefully this science will be even more refined because there's a wide difference in physical therapy regimens in a center like ours at Johns Hopkins. Obviously, we're an integrative, multidisciplinary center of excellence. There are more of those, and even there are satellites to that where we I think, help train other people to understand how to rehab patients with myositis. So while it is an expanding genre, and people, both physicians and therapists, are understanding how exactly to rehab muscles, I think that is a really important component of your at least slowing the decline. In some cases, I've said this publicly, I mean, really very early on, a relatively high profile patient who showed me that when exercising in the beginning of the disease, actually you can get stronger in some cases, or at least maintain function. The other thing I will mention here that I do think decreases the um, inevitable decline in muscle function is something called blood flow restriction therapy. Some of you have heard about it. I think even it was featured at the Myositis Association annual conference last year when they held it in my fantastic city of Baltimore. This is a therapeutic option, which sounds unusual, but it's a constriction of just the blood vessels, only the veins. It doesn't occlude your arteries or compress your arteries. And then you exercise that muscle in a very defined fashion, often daily, several times per week at least, and then you follow those patterns of how are you improving with regard to function. So again, this is not a webinar about blood flow restriction or BFR therapy, but this is something that I feel like is worthwhile investigating further. This is done both virtually, as well as some centers are specializing in that. But I think it's very helpful because many of these programs can be actually done at home. So I think there's more on that. We're looking into that in a very scientific way now, trying to get some data that I can speak behind other than my own, uh, before my own eyes, watching people improve with several people have improved with that. So, and the other thing I would say is make sure you get plenty of sleep. So good nutrition, sleep hygiene, and exercise. I know that's not the amazing new breakthrough you want to hear about, but I think it's what you need to do to temporize the disease to get to the next breakthrough. So the way I see this approach, and I always tell my patients that in addition to trying to preserve your function for today, or at least decrease that decline, is to get you to the next milestone where you will still benefit from the therapy. Long answer, but I think that answers a few, hopefully.
Actually, you answered probably about three questions that we had, so we're good. Speaking of sleep hygiene, this person hasn't been able to sleep at night in over a month due to bilateral leg, foot, and thigh numbness, tingling, cramping, and pain. Do you have any suggestions for them so they can get better sleep?
So this is interesting. And again, I think that at the top of the hour, you saw that like this doesn't constitute medical advice. It's so hard for me to answer this question without an exam. So I'm going to be honest that this is a little tough. I'm going by your history, but not your exam. You're describing almost certainly neuropathy. The fact that I don't know if you've only can't sleep for a month or if you only had these symptoms for a month. So again, the way I think about your symptoms are that these are neuropathic. They're almost certainly nerve and not muscle. So yes, muscle cramps and pain can be from the muscle, but I think what you're describing sounds more in the nerve portion of the body. So again, this could be a peripheral neuropathy. The fact that it's on both sides, it can suggest it's either coming from the spine or it's coming lower than that in one of your peripheral nerves, which is not the spinal canal itself, right? So I think in that case, and you're not going to like this answer, but one of the best ways to try to discern where those symptoms are coming from is an EMG and nerve conduction study. So we call it EMG and nerve conduction velocity. You really want the nerve portion of things there. Many of you have probably had an EMG to look at the muscles. We often do these in tandem because there can be neuropathic pain or dysfunction as well. Nerve related pain is actually in the minority of patients, I think. Again, patients always educate me, so I'm careful to say that I know. Maybe you know something I don't. I'm always willing to listen to a patient, and that's sometimes how I learn about a new symptom. Really, it's patients that tell me to look a little closer. I would say that peripheral neuropathy, while I have seen it in my patients, it's not a common feature. That is a little bit untrue in IBM. So I don't know the kind of myositis you have, but we do see neuropathic and myopathic features. So nerve problems, muscle problems, more often in IBM than the other myositis subtypes. So how can you sleep? The first thing I think you need to do is figure out what is causing it. There are medications that are nerve-related medications, things such as gabapentin, pregabalin. These are called Neurontin or Lyrica by trade names. They actually really do dull that kind of pain to get you to sleep. Your symptoms are so global, meaning they don't just affect one part. So I don't think this is a compression problem. Sometimes if you have just some lateral thigh problems on the outside of your thigh, that can be a compression of the nerve that's actually hanging sort of under the belly, but that's not what you're describing here. So I know this is a little bit probably you feel unfulfilled that I haven't told you how you're going to sleep, but I think the first thing is to figure out where it's coming from. If it's your back, you're going to need specific strategies for your spine. If it's your peripheral nerves, you can take those medicines that I talked about, but then your doctor may also rule out all the reversible causes of neuropathy. And they range from anything from B12 deficiency to folate. There you will have a full battery of testing just to make sure your thyroid works and your vitamins are in order. To make sure that it's not an easily reversible cause. So that's how I'd start, and I wish you luck. And I do know how important sleep is for sure. So I sympathize, but that's how I would work it up.
Our next question is a DM question. What looks most promising in trials today for DM?
I think we are in an era of unprecedented potential in dermatomyositis. I think maybe we overshot a little. So I always say that we sort of came out of the COVID pandemic and shot out all of these potential therapies like you were shooting them all out of a cannon. It was suddenly we had very little, and then we had so many options. Part of that problem was that the trials competed against one another for a small patient population, relatively. So this is a relatively rare disease, as you know. So I think that while there was a lot of therapeutic options, excitement, three pathways emerged. And that was probably because they didn't directly compete with each other. It's probably the timing of how they came out. And the way I think about them is this way. And it's not only dermatomyositis, but we'll talk about dermatomyositis. Some other types of myositis could, including overlap or maybe the antisynthetase syndrome in some cases, can also benefit. These are large, and if any of you are new, you're like, wow, that's a very, what did you just say? I recognize that these are large medical terms, and I am a splitter. Not in medical school, we're a splitter or a lumper. Do you lump everything together or you split? I tend to be a splitter rather than a lumper because for me, I need to understand the disease in the way it works pathologically to try to hone in on the right treatments. You don't want to lump too many people together that might look alike clinically, but don't look alike in the way the disease is expressed at the biological level. And so therefore you don't want to dissuade or inhibit a therapy from working. But I think despite saying that, dermatomyositis is a prototype, and then some other myositis subtypes will likely benefit from this as well. So the three categories I think about are something called anti-interferon beta. So there's an anti-interferon beta drug, and that is from Pfizer. There is an or an FcRn receptor blocker. FcRn receptor antagonists work a little bit like IVIG. So they block, it's very hard to sort of do this without slides. I can just show a model, but they essentially block the recycling of antibodies so that if the antibodies are causing the problem, those self proteins you're making, they don't get to recycle and keep causing the problem. It's like a sink, they take them out. Interferon beta is almost certainly one of the biggest players in a dermatomyositis. Interferon is a chemical, right? It interferes with things. Interferon, you can have alpha, you can have beta, you can have several types of interferon. They are present, those chemicals are present with viruses, and they're present highly in dermatomyositis. And several investigators, among them Dr. Ruth Ann Vlegels, Dr. Ferrantino, and others, have shown that the interferon beta pathway probably plays a large role. So blocking that pathway, and that's dazukibart is the name. I don't know what they'll eventually call it as a trade name. I'm also taught not to speak in trade names, but to speak in the generic names. And I realize it's like impossible to spell or say these, but that is dazukibart. The other one is even harder. It's called efgartigimod, right? Are you following all of this? And the trade name for that right now, that one, the FcRn receptor, is called Vyegart. And that's, I don't know that they'll have the same name or it'll be the same name or not. That's already approved for another kind of sister process called myasthenia gravis, where there's an antibody between the nerve and muscle junction that impedes that union, and patients have problems keeping their eyes open or breathing. And that drug has been helpful there, as has IVIG. So we think the same process may be helpful for dermatomyositis. The third bucket, again, the current one, and there are more, I think there are more coming down the pike, but I think these are the three leading horses coming to the finish line where we'll see something soon. The third mechanism is JAK inhibition. JAK stands for Janus kinase, JAK inhibitor, and there's something called a JAK TYK2, TYK, TYK2 inhibitor. That is also turning off these inflammatory pathways in dermatomyositis. I think that's promising for many reasons. It works quickly. It's usually an oral agent. And we've seen some benefit with Xeljanz or tofacitinib in a small trial that we did locally at Johns Hopkins. Dr. Julie Pack was the main author and really performed all of the assessments in that trial. I was the senior author of that study. And we were amazed not only at how well people did with JAK inhibitors, but how quickly they got better. So all of those three, I think, are our three most promising drugs to come in the pipeline. Other people are thinking about blocking complement. Complement's a little hard to explain that, I think, but essentially that's part of the immune system as well that is implicated if you look under the microscope at the muscle cells and the blood vessels that are surrounded by those muscle cells. And so there is evidence that complement deposition is something that we should be targeting. So that's, again, a very scientific answer, but I think the most important answer is that there are probably 2 to 3 competitors, but also maybe helpful. I think in some ways they compete against each other, but in other ways we will see them start to be used for specific patient populations. We might notice that some are particularly very helpful for dermatomyositis skin. Others might be more effective for muscle. I think they all work for both. The most impressive quick turnaround I've seen are with JAK inhibitors for the skin. So I suspect that might be the fastest mechanism. It may not be the most effective for every patient, but it is phenomenal to know that we went from essentially steroids to these. And what is approved is IVIG, and you know this, and that is actually done by, that study was done specifically by Octapharma. So it is the Octagam brand name specificity of IVIG that did the pivotal study. This, of course, was done by Dr. Rohit Agarwal and many other of my colleagues, who showed that in really 24 weeks, you could see a very statistically significant difference. The one thing between placebo and an active drug or active product, actually IVIG is not a drug. It does not, it is a blood product, and a lot of people don't even fully know how it works. We think we have some idea. I've mentioned that earlier, but that is an immunomodulator. It modulates the immune system. But one of the things that trial showed, as you know, it's called, many of you who are, and many patients I know on this webinar are probably more well versed than I am. You all challenge me when you come into my clinic, and you're so smart and so well read about this. But this is the ProDerm trial. And the ProDerm trial really also highlighted something we had not really expected, and that was the placebo response. So apparently, for reasons unclear to us, there is up to a 40% or higher placebo response rate. People like, for whatever reason, being in a trial. We don't exactly know what portion of the trial that's responsible for such a high placebo rate, but that comes into play when you're trying to get a drug approved through the FDA, because of course you have to show a separation of those two curves for people doing better on active product and people doing worse on placebo. And when so many people do well on placebo as well, it gets harder to show that difference. So that's what's sort of coming down. I think we're in an unprecedented era, and I am crossing my fingers and toes that we have 3 novel agents that come through the pipeline, and that we can start using them in our patients in the near future. Again, super long answer, but hopefully is comprehensive.
We've got a question about artificial intelligence. Is AI being used, or do you see it becoming a more useful tool for research in myositis?
So I suspect someone is using AI. I've already started to look at how we can use AI in large cohorts like our own. Many of you who have seen me know that I always say that I try to freeze you in time, right? I take a sample of your blood, we put it in our freezer at minus 80 degrees, and sometimes we don't touch that sample until we look at your sample along with an aggregate sample of other people, maybe in that same bucket. In other words, maybe somebody, all people would have a diagnosis of IBM. All people have an overlap. All people who have JO1 positive antisynthetase syndrome. And then I think that absolutely AI can see what we cannot. I've said this before publicly. I think it's good for all of the ills that will certainly beget society from AI. I think that the best use of it is going to be in medicine. Now, many doctors wonder if it's going to put us out of a job, but I would say for now, the short answer is that I think it's the early days of AI. I think it's becoming a little more sophisticated. And you can imagine that if you have numerous biomarkers for which you can't really see the pattern, but the computer can. How does, and we've already been doing what's called unsupervised clustering, where you don't tell the computer what you think, you let those results tell you. These are the kind of results that taught us a lot of things, like separating out different types of myositis based on clinical characteristics or biomarkers, which means blood samples or other biological samples like muscle or skin, or telling us maybe in the future about who might respond better to what therapy. I can see that as finally bringing the precision that I've promised since I've been doing this for almost 25 years. I used to tell people that I had a patient years ago who said to me, "Do you just like throw darts at the dartboard? Is that what this is? It seems so loosey-goosey. How do you know which patient gets which drug?" And I said, "I do. I actually throw the dart. I've just thrown so many darts that I think I can probably hit the bullseye a little bit more, but I'm human. Imagine the AI thrower, right? We know how fast a computer, and especially AI technology with large language models that are coming about that change every day, they can throw those darts so fast and so accurately. I bet that they're going to be able to outpace me at dart throwing. And they will say, when that, my dream is that when you come to see me, I say, Mrs. Jones, Mr. Smith, I've looked at your, we're going to take your biomarkers and look, you're going to be a drug X responder. Let's do that instead of the pathway that many of you have had, which is start slow, build up, or the FDA or not the FDA, but the insurance payers will tell me exactly what I can't use until you already failed drugs, which is mind numbing for a physician that's almost certain they know what you will benefit from, but I have to watch you systematically fail drugs until those drugs can be given to you. I suspect if we have enough data and AI can provide that precision, we can make an argument to payers that, hey, listen, the patient will do better. And most importantly, for a payer, it will save them money. So it's win-win. And I think that's what AI precision will bring us in the future. I'm very hopeful for that. I would say, though, that we're at the very early days of this, but I certainly hope maybe in a year or certainly 5 years, we'll say, remember when you asked that question about AI? Look what we've been able to do.
Your thoughts about senolytic drugs relative to IBM?
I'm having a little hard time hearing you, Rachel. Your microphone, I think, cut out. Something about IBM. Can you try again?
What are your thoughts about senolytic drugs relative to IBM?
Senolytic drug. Can you spell it? Senolytic. I know nothing about senolytic drugs. Not even sure I know that category. That I will.
Aging drugs.
Yeah, I mean, I could tell that's what it means, but I'm not sure if the person who asked the question has a specific drug in that category. I'm not an aging expert. So if there's a specific drug, like an anti-aging drug, I'm not sure if this is what you're referring to. One possible drug that is, I think, again, I'm not as familiar with senolytic, but I would assume that you mean to slow down the aging process would be metformin. Metformin's been looked at as an anti-aging component. This is an anti-diabetes drug. Looks like a thumbs up. Maybe I got it right. There are studies showing that use of metformin have off-target effects, not only in glucose control, sugar control, but also in decreasing or slowing down metabolic functions to decrease aging. I will say that I've looked at this a bit, and there's no signal per se that we could see in those who took metformin, those who did not, for other reasons, for diabetes. We've never studied that, and I'd have to look to see if there's any credible literature, I don't recall it, on studying that in a larger IBM population. So I know why you're asking it, because I've said the words out loud, that I think IBM is an abnormal aging process, right? It almost seems like accelerated aging or degeneration, but also aging. So I don't know enough about anti-aging drug class to really comment, but I think it's what's the word? I think it's a provocative question to ask, and I think it's maybe a little premature in me being able to answer it. And if there's any further comment I can make, I'm happy to look at a further question.
We have a question about how can a patient get transferred or referred to Johns Hopkins Myositis program?
Yeah, here's my infomercial. No, I did
Yeah.
not plant this question. Actually, we have, if you actually just Google the Johns Hopkins Myositis Center, you can walk through. I must say, it's a bit of an aging website that, speaking of aging, I think it needs some anti-aging drugs to bring it up to maybe the 21st century. It has all of the information about referral. The best thing, if you want to be referred to a center like ours, one thing I will say, for better or for worse, and I wish it were better, but for numerous reasons, which I will not completely go through today, our wait list is long. There are only so many of us. There's a lot of you. And we carefully triage everybody who is referred. And that triage process is not originally just me, although we all rotate to do that. It takes a while until your record comes to my eyes or one of my colleagues' eyes that triages the record. What's most important is it's wonderful if your current referring physician, be it your primary care, your neurologist, or your rheumatologist, gives a brief summary with a cover sheet and says, this is the medical history. If you have a new diagnosis, we do want to see you. These are the people that I do want to put at the front of the line for many reasons. You can help us, we can help you. I do think that we do very well together when patients who have been brand new diagnosed come to see us, and you can highlight that and say, new diagnosis. Your physician, not have your physician call for every one of you because it doesn't help. But if there is a critical need, like for example, I did have a very sick person who had anti-MDA5, newly diagnosed, that needed care. That's somebody that does sort of go to the front of the line. So we do triage as urgent or non-urgent. I mean, not all of you are somewhat urgent, I get this, but urgent in the sense of needs to be seen soon versus goes into the queue. So those people maybe can jump the line, but everybody else sort of comes in the way that you were referred. When you were referred, in addition to a cover letter, and by the way, I would say that this is not unique to Hopkins. This is whenever you're going to another excellent center. I certainly, by all means, I love to see you all, and I think we do phenomenal work at Johns Hopkins. I'm super proud of what we've built, but I have amazing colleagues at the Mayo Clinic and other wonderful centers throughout the country who can also see you anytime that you're referred. A cover letter, if you've had antibodies, myositis antibodies drawn, any other blood work that's recent is helpful. And then other antibodies, again, this is like a rheumatologic workup if you've had this, an EMG, nerve conduction, PFTs, pulmonary function tests, and any MRIs of your muscles. Those are the core things we would love to see. Not everybody has those. And if you haven't had them, we've thought a lot about giving a referral sheet that checks these off that says has had or hasn't. That's easier. I think that that's really helpful, and that you don't make us do homework. If we have to track down your records, even if you're referred, then you get bumped until we get the right records. So I think the best thing you can do for any referral to any tertiary care center is have those documents in hand.
What is the newest methods of determining muscle wasting diseases with extreme pain upon standing and walking more than 10 minutes, besides an MRI, blood work, and electrographic tests that could not determine exact diagnosis?
Again, this is a very specific clinical question to one individual, so I want to be careful in stepping into this. But what you do describe, if you haven't found any example in, I'm sorry, any reason for your symptoms in imaging, I would think that this could be a vascular problem. So something called claudication, where the blood vessels are compromised, that's usually what inhibits people from walking 10 feet, 10 meters. So I would speak to somebody who, or at least speak to your doctor to see if they agree that maybe a vascular vascular medicine consult could be helpful to you. Those are different tests and they can test the integrity of your vascular system. Are you actually getting blood flow to where it needs to go? Because you can imagine when we go up to walk, we use our blood vessels and engage them in a much more vigorous fashion than you do when you're sitting still. So usually you do your own stress test of your vasculature, of your blood vessels when you move the way you do when you go to walk, because it takes a lot to have adequate blood flow to allow you to walk without pain or without compromise of function. So you're describing maybe again, caveat is that you're not my patient. I'm not seeing you. I haven't examined you. Sometimes even when I examine you, I don't know the answer. But I would say that if you haven't had that testing done, I might look for something called claudication. I have had that happen in my patients. It's unrelated to myositis, but it's a problem, particularly if you happen to be probably over the age of 50. We see that more and more as people age.
One second.
I can take a few if
We've
you want
had,
to. I see a few great ones that I'd love to answer.
oh yeah, go ahead, please.
Yeah, so I see one that I like, and that's antibodies are negative. Can the diagnosis still be myositis? I love this question for two reasons. So, first, the answer is absolutely yes, but I get a little more suspicious when you don't have an antibody. It's a little bit harder when it depends on what you look like clinically. If you have a rash that looks like a textbook rash over your knuckles and over your eyelids, and you don't have an antibody, I'm like, okay, well, that's almost certainly dermatomyositis. It's antibody negative or antibody unknown. So first thing is the antibody really negative? There is a series of testing that we now have, and I love autoantibodies. I love myositis antibodies, but I don't love that all the testing is not standardized. So I think we're in an era where we're still trying very hard to get a panel that we believe. We send our antibody testing out to Oklahoma, to the Oklahoma Medical Research Foundation, OMRF. This is something that is not usually available for most clinical laboratories. This is an academic partnership, and it takes a very long time to get the results back because they're all done by hand. They are using hand methods to look for these antibodies with their eyes and a gel, which is called, a gel electrophoresis. These specialized tests, this is not automated, it's done by hand. So those are accurate, but slow. And so some of the testing is just not accurate. We also test in our research lab, and sometimes we can see antibodies that haven't been picked up clinically. We're unable to disclose those to you because they are not done in a clinically certified lab. So it must be done in a clinically certified lab. But if that happens, sometimes I can say, okay, let's try to find them in a different way that's clinically actionable. The second thing is somewhere between 20 and 40% of patients probably do not have autoantibodies. I am much more suspicious if you don't have a disease that looks like IBM. So inclusion body myositis does have an associated antibody, anti-CN1A. Some people call it NT5C1A, but CN1A, that antibody is commercially available, fewer than 50% probably. It might be between 30 to 50% of patients, depending on which cohort you look in, have those antibodies. So if you don't have that antibody, it doesn't mean you don't have IBM. If you don't have a dermatomyositis antibody, but your rash looks like a textbook that I saw in medical school, you have dermatomyositis almost certainly, or you could have the anti-synthetase syndrome with a similar looking rash. But again, those antibodies are usually a little easier to find. But then I think you have antibody unknown dermatomyositis. I get a little nervous where you have maybe muscle edema, fluid in the muscles in imaging. You might have a little bit of, you can see a myopathy, a muscle problem on electrical testing on EMG, but you don't have an antibody. There gets a little dicier because there are so many mimics. And again, without clinically evaluating a patient, this is a hard answer for, I don't know the context in which you've asked it, but it can still be myositis. But I do think that those patients that don't have IBM features clinically, that do not have muscle, I'm assuming maybe your muscle biopsy also has inflammation. If you have a negative muscle biopsy, that's a little harder. But if you have a typical rash of dermatomyositis, I'm much more less anxious about no antibody. I get a little anxious in those syndromes that don't have the typical rash and may have atypical features or none found on biopsy. So edema or fluid in your muscle on the MRI, for example, can be what's called denervation. I'm not in any way saying that you have this diagnosis, but I have on occasion made the diagnosis, even as a rheumatologist, in concert with my neurologist, neurology experts of ALS. So there are mimics of myositis that are not myositis, and those become most critical when there are no other features. The other thing to look at are other features of connective tissue disease. Those would be lung disease, so interstitial lung disease, Raynaud's phenomenon. Do your hands turn blue in the cold, and has that been happening only lately, or is it a long-term thing? So Raynaud's can be its primary Raynaud's can be common in the 20s, especially in young women. But if you suddenly have Raynaud's onset over the age of 40 and you have some muscle involvement, but you don't have an antibody, or you have interstitial lung disease, by all means, then you're in my wheelhouse. I don't know what to call you, but you're in my clinic, my wheelhouse, my vision. If you don't have those features, so no arthritis, no lung disease, no Raynaud's, no weird fevers, and you just have some muscle problem with no rash, that's harder. And there's where I start drilling down. And very recently, two people in 1 week who had the diagnosis, one for 24 years who came to see me who had a diagnosis of polymyositis. It is my least favorite diagnosis. I'm always trying to debunk it. I see polymyositis and I go until I can find the diagnosis that it really is, because I often do not think it's polymyositis. I think there are several other things, and we can talk about what that can be. That I had two adult onset muscular dystrophies in the span of a week. Both their testing came back. I had seen them all within the last 6 months. So I know, I see, like I see the scary face, but I'm just telling you that I think it's important that if you've had no response to medication, which is what happened to this person, inflammation on biopsy, absolutely, to the naked eye, yeah, a lot of the adult onset muscular dystrophies have inflammatory features on biopsy. So I think you need, at that point, an expert either in neurology or rheumatology with myositis background, but somebody, neurologists are very helpful here because it's often in their wheelhouse, not myositis. Rheumatologists can make that diagnosis, but it's usually neurologists that have a better feel for the mimics of myositis when it comes to muscle. The skin can be a mimic in a different way. It can mimic occasionally. People get confused with lupus, psoriasis, and other diseases, but most of the time, the dermatomyositis rash is pretty telling. Again, very long answer, trying to anticipate what might the questioner or the person who posed the question need to know, but those are all the ways I think about antibody negative myositis.
Do you see any other questions that you like? I
Yeah, I love it. So, a couple of them. So, I think there was a lot of these are like very specific to the patient. I do want to mention pelvic floor. So, could I address the possibility of pelvic floor muscles or issues there being associated with myositis? Dr. Marilee Needham in Australia and her group did actually look at this very question, and they have found it. I will say, like, I just want to at least validate for women that say they think there's something wrong with their pelvic floor. Certainly, obviously, anybody who, any aging woman in general, can notice some pelvic floor dysfunction. Certainly, many of us who have given birth, by the time we're reaching middle age, we're certainly at risk for that for sure. And I think women in general in medicine and science can sometimes be completely dismissed. So the first thing I'll say is I hear you. And I think it was actually my other colleagues, my junior colleagues, who brought it to my own attention, who said, I think there's something there. And I think that you tell us that it's true. So I see hearts. I really hope that you know that you're heard. And yes, and there's now data. And Dr. Needham's group and others are looking carefully to try to determine if they can do anything about this. I don't know necessarily beyond Kegels and other exercises that we would do for non-inflammatory causes for pelvic floor dysfunction. Why it probably happens, again, one reason, there's some people that think there's certain antibodies that might be associated with this. I don't have enough data to say that today, but I think that's provocative. There also is probably degeneration of the pelvic floor muscles. So the more atrophy you have in the pelvic girdle, the more likely it's going to be that you'll have pelvic floor dysfunction. Also, people don't talk about this, right? People do not want to sit there and talk to their doctor about things that are classically in society felt as embarrassing or shameful. And I think it's both the onus of the physician and the patient to raise these questions. I must say that honestly, these are questions that I say this as a doctor, but I also look like a deer in the headlights when it's raised because we just have such a minimal information about what to do. But I will refer my female patients to a urogynecologist when this happens. Men, and probably experience this in the form of erectile dysfunction as well. Again, what man wants to sit there and talk about this with their doctor? But my male patients that have feel relief that this actually may be some part of their disease. Again, I don't know how much we know, but I think it's worth asking these questions. To me, these questions are about being a whole person, being healthy, and having the courage as physicians and patients to have a discussion so that you are a healthier person. So I think TBD on pelvic floor, but I think it's so important that you've raised it. And it's something that I know Dr. Needham, gosh, she leads, talk about somebody with heart and passion. She's a neurologist in Perth, Australia. She's my sister in science and just really in life. Love that she listens to her patients. And I really think that we're going to know more because now we're assigned, we know the assignment, right? So it's our job to help you.
Keep on picking. I'm letting
Okay.
you run the show now.
Oh, I
So
love this idea that someone said, yeah, okay, I've got right. I'm running the show now, Rachel. I'm taking over the question. No, I say
yeah,
since some of these are so good, I really want to like get to them and I can't get to all of them.
I
One,
know you
I
can.
think is so I've been on, this is a specific question, but I think it has applicability generalizable for your audience. I've been on mycophenolate for dermatomyositis for 9 years and I've remained stable. Is there a possibility that at some point this may stop being effective? So the answer is yes. People do sometimes develop inefficacy to the drugs that they take, and you have to rotate, right? It's like sort of like rotating tires. I feel like for whatever reason, this happens occasionally with IVIG. I have to brand switch. I have to take them off. I need a drug holiday. Again, it's not super sciencey. It's just sort of trying to figure out with the patient. But I will say that most people can maintain stability for years and sometimes decades on a medicine. What I want to bring to your attention, and again, I do not want to challenge your physician who will say, who told you to stop this medicine? I'm not telling anybody to stop their meds today. What I think has been sort of perpetuated as I have patients who clutch the bottles of their medication saying, what do you mean I could potentially reduce or stop this? And I do, and I get patients some off medicine. So I think it's at least worth a conversation. Some patients, I wish I could tell you that I have a miracle and all of my patients are off medicine. That is far from the truth. Many of my patients are on, I never say lifelong, I say foreseeable future, are on foreseeable future meds. And that keeps the disease at bay, and that's fine. Sometimes I do pull those meds away very slowly. I never just say, stop it, never. Pull it back, maybe one tablet at a time from mycophenolate. Many people are on 6 of those tablets, 3 in the morning and 3 in the evening. Can we just take one away for maybe 6 months in the evening? Maybe we could take one and one. So, especially as we age, those medications do have other side effects. And so, I get a little bit thoughtful trying to say, am I just continuing to treat in the same way because this is what we're used to? I had one woman who all but refused to take her medications away. She said, "No, I was told from a doctor that you'll let the genie out of the bottle, it'll never come back." And actually that is a risk. I'll be clear. There is a chance that if you stop your medication, you might not be able to pull that genie back in the bottle. That is the exception and not the rule. So how risk averse are you? How thoughtful, can your doctor and you be together and maybe reducing to the most viable minimal dose? I think either lower dosing or sometimes stopping it altogether is helpful. I'll make that comment once with regard to MDA5. I started to notice that MDA5 in particular, as a subset of dermatomyositis, can be quite frankly, one of the most deadly and one of the most severe if the lung disease is severe, or sometimes one of the most treatable where patients come, I call it the freight train, where just everything, right? It comes on like this huge avalanche of symptoms and then it just goes away. I really strongly believe that that is an environmental pathogen, environmental virus, and we have some data that suggests that there actually may be an infectious link to some of these diseases. But we did the study and showed, at least in our cohort, this is a single center cohort, that 20% of our patients, 1 in 5 nearly, could stop their drug and their disease never came back. So I just want, again, please do not look at this webinar and say, call your doctor and say, I heard this woman tell me that I should stop my drugs. That is not what I'm saying. What I'm saying is please be thoughtful about maybe reducing those drugs over time. You might be able to be on a slightly lower dose, and in the best of cases, over months to years, wean that dose off. That's all I'll say about, I think it's important for that. Um, let's see. Okay, let's see. If you've got another one, let me know. Okay, I like this one. This is one I like this one. So 15 years ago, it was detected I have the anti-Jo1 antibody, my dermatomyositis. So she's got the anti-synthetase syndrome plus a rash. I mean, right, lumper splitter. We can call that maybe semantics. We'll call that dermatomyositis. I call it anti-synthetase syndrome plus a rash because I think they're different. It's been medically controlled, good for you, for years on 12.5 of methotrexate weekly. So it's a low dose of methotrexate and a tiny dose, 2.5 of prednisone daily. And I feel great. Yay. Should having the anti-Jo1 antibody worry me? And I'm not sure if you're asking if you're saying if I still continue to have a positive test for the anti-Jo1 antibody, there I want to caution you to say that we see this positive for a long time. Some patients lose their antibodies, some do not. One of the most impressive and odd things that I saw is this is a much more serious case, and this is very rare actually. I don't have a lot of people, thankfully, with anti-synthetase syndrome to go on to lung transplant. It's actually so unusual that I remember the case, but she had to go on to a lung transplant. This is probably close to 20 years ago. She got new lungs. She did beautifully, actually, for many, many, many years. Actually, she lost a follow-up as she moved. And I would test her Jo1 antibodies. We generally don't retest antibodies because we don't really know what they do. And they were still present. She had no problem. They did not inflame her new lungs. So it teaches me that, yes, we think these antibodies cause the disease to some extent, but most people can retain a small amount of them. And maybe there's a threshold where above some threshold, or sorry, below some threshold, they probably don't cause disease. I think this is a TBD evolving question and scientific exploration that's needed. But I suspect that you are the exception, not the rule, if your Jo1 antibody is positive for years or decades. If I test serial samples of my patients, they often don't go away. My2 or Me2 or Mi2, I still don't really know what that antibody, we showed that in some patients, it goes away. It disappears, but in others, it does not. It may be associated with a better prognosis if it goes away, but I have plenty of patients that are in remission who continue to have antibodies in their blood. So unlike lupus and other diseases, I don't know that we need to be antibody negative to say that the disease is gone. It's nice. We really like that, but I don't think it's sufficient on its own. So I wanted to make sure that I spoke to that. I don't know, Rachel, if you got another one, otherwise I'll speak to nutrition. If people talk about nutrition, I'll actually this one. So what
Yes,
role do
actually, yes.
nutrition, anti-inflammatory diets, specific supplements geared towards individual deficiencies contributing to muscle health can or should play in managing the effects and speed of muscle wasting with IBM? So I'll say that the problem with, okay, so there's a lot of problems with this, with what I'm going to tell you. First, I'm being clear, I went to medical school a long time ago, like a quarter century. I think I had 4 hours of nutrition training and 4 years of medical school, and I'm not sure it ever appeared again in my training after that, right? So doctors, I think it's better today. It is better. Actually, I know it is because I've trained medical students, but still, we are not nutritionists. Actually, we're probably the worst people to give you nutritional advice because we're not trained that way. It's terrible. It should be you are what you eat, but we don't always think this way. And we're too busy trying to stamp out the fire rather than figure out if we could just decrease the flames by what we put in our bodies. So people ask me about nutrition all the time. One of the things I try, again, this is not specific to myositis, but something like an elimination diet. The Whole30, I do not work for the Whole30 plan, but this is an elimination diet where you take things out of your diet and then you slowly put them back in. Again, pseudoscience in the sense of I'm not sure it's totally true that some of those components of this diet, if your diet are inflammatory, but for whatever it's worth, some people, for whatever reason, find dairy to be inflammatory. Other people find legumes. I think both dairy and legumes are an important part of a whole diet, but if it's not part of your diet that helps you, take it out. So elimination diets might help you. When you talk about specific individualized deficiencies, I think there might be a time when we might be able to give you some kind of like mitochondrial cocktail where we know what deficiencies you have and we can treat that. I think that's a future possibility. Today, however, we have talked about IBM with cocktails is sort of the probably not the best terms, but this series of vitamins and amino acids, et cetera, that we recommend. You know, I have a handout and I give this to the patient. And generally what I say is, I'm not sure it'll help you, but it's almost certainly not harmful. However, the only harm it is probably is to your wallet because these are all out of pocket costs. I do not think I have seen a single supplement or a supplement combination that has really helped in IBM other than creatine, where there is some data out of Sweden. And some of my patients do like this because it helps to build muscle or bulk. A lot of people, as you know, who train, who are bodybuilders, use creatine. So that might be helpful. But again, I mean, by no means are you going to halt the disease, but it may be helpful in providing some bulk.
We have time for one more question. We had several questions about dysphagia. If you could talk about that and treatment.
Yeah, that's tough. So how do we deal with swallowing deficiency, swallowing difficulty? I think in the non-IBM subtypes of myositis, we see a lot of swallowing difficulty in very severe disease. And many of my patients, several of my patients have had a gastronomy, a G tube, right? A PEG or a peripherally inserted tube into their stomach or intestine. The reason that, or into the stomach, the reason that we do that is because it's unsafe for them to swallow because it can aspirate into their lungs. I do not have a single patient, personally, that started off with a G tube that still has a G tube for non-IBM. So I think that swallowing dysfunction follows the severity of the illness in dermatomyositis in particular, for sure. In IBM, the swallowing dysfunction can be multifactorial. There's a lot of things that can happen. I do think you should always have an official swallowing study. Every once in a while, we see something called a Zenker's diverticulum. Anybody could have this, including somebody with IBM, where there's a little, extra tissue there, and we say, "Huh, we've been blaming it all on IBM, and it's not this." Most of the time, it is IBM, but the same person that does the speech and swallow specialist can teach you how to safely swallow. In some cases, chin tucking and other things are so important because really the risk to you is not the swallowing problem as much as the dysfunction where can go into your lungs and cause a chemical pneumonia, an aspiration pneumonia. And obviously, we don't want you to become malnourished. So to be able to get enough calories, we want you to know what you can swallow safely and how to do that. So I recommend a formal speech and swallow evaluation to rule out other causes and to help actually train your muscles. In rare instances, we do stretching of the esophagus as well as esophageal dilation. Each one of those things that I spoke to is individualized based on the testing and that you've had and expertise from a swallowing dysfunction clinic or speech and swallow specialist that can help you. I think I've made my time with maybe 1.2 minutes to spare.
Thank you so much. Do you have any closing remarks you would like to make?
Well, I think I've always said that, to the word doctor is to teach, right? It's Latin for to teach, but I think that I always say that the patient has been my greatest teacher. It has been one of the biggest, really, the pleasures of my life to be able to take care of all of you that I have been able to. And even if I don't see you personally, it's a pleasure to try to give you information to empower yourself. I just think the last thing I would say is that every patient should ask of their physician to make sure that they've got an adequate explanation so that they understand their disease. I think every patient, regardless of educational level or anything, can absolutely be a learner. And it is the job of the physician to tailor that discussion so that their patient understands their illness and what they can do about it. So I think knowledge is power. I think we're at the precipice of some amazing, hopeful treatments for all of IBM. And I'm waiting with bated breath. I hope I have some good news soon.
Thank
Take
you
care.
so much. And please, we would love to see all of you in the audience at our next webinar, Myositis Research Insights, featuring Dr. Julio Huapaya. And then, of course, TMA offers roughly 45 support and affinity groups designed to decrease isolation, share knowledge, and inspire hope. You can register today. The link is in the chat. And this year we celebrate 30 years of convening the myositis community at MyoCon. We hope to see you there. Thank you and have a great day.
Thanks, TMA.